we shall discuss about the anatomy of shoulder joint. The shoulder joint is a synovial joint of the ball and socket variety. The ball and socket joints are also called multi-axial or polyaxial joints because they permit movement along the three axes, that is the anteroposterior, medial lateral, as well as rotational movements. The articular surfaces of shoulder joint is formed by the glenoid cavity of scapula and the head of the humerus. The shoulder joint is a weak joint because the glenoid cavity of the scapula is shallow and is not able to hold the head of the humerus in place. The head of the humerus is about 4 times the size of the glenoid cavity, so there's a large amount of mobility but less stability for the shoulder joint. Because the head of the humerus is much larger than the socket of the joint, which is formed by the glenoid cavity of the scapula, a soft fibrous tissue rim called the glenoid labrum surrounds the socket to help stabilize the joint. The rim helps to deepen the socket by about 50% so that the head of the humerus can fit in. This glenoid labrum is a fibrocartilaginous rim which covers the margin of the glenoid cavity and helps to increase the depth of the glenoid cavity. This contributes to the stability of the shoulder joint. Apart from the primary socket, which is formed by the glenoid labrum, there is also a secondary socket which is formed by the coracoacromial arch. So the coracoacromial arch or the secondary socket is formed by the coracoid process, the acromion process, and the coracoacromial ligament that passes between the coracoid process and the acromion process. So the coracoacromial arch protects the joint from above and prevents the superior displacement of the shoulder joint. Yet another structure contributing to the stability of the joint is the musculotendinous cuff of the shoulder or the shoulder cuff, which is formed by a group of 4 muscles and their tendons, namely the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. They connect the scapula and the humerus. The shoulder cuff grasps the head of the humerus and pulls it medially to hold it against the glenoid cavity and helps in rotating the head of the humerus against the glenoid cavity during joint motion. Thus, it helps to stabilize the shoulder joint and enable arm movement, such as raising arm overhead or rotating the arm. Now coming to the ligaments of the shoulder joint, the first one is the capsular ligament, which permits the free movement of the shoulder joint and is arranged all around the joint, but it is least supported inferiorly, hence the inferior dislocation of the shoulder joint is common, and this can lead to axillary nerve damage. Although the joint capsule is continuous, there are 3 gaps or apertures within the joint capsule. One for the passage of the tendon of long head of biceps brachii muscle, and 2 gaps for allowing communication between the joint capsule and the bursa. Out of the 3, the first aperture exists between the tubercles of humerus and the tendon of the long head of biceps, passes through it, covered by a synovial sheath. Out of the next 2 gaps, one is in the antero-inferior aspect of the joint and allows communication between the joint capsule and the infrascapular bursae, and the third gap is found inferiorly and allows communication between the joint capsule and the infraspinatus bursae. The synovial membrane lines the inner surface of the joint capsule, and it is also reflected to the glenoid labrum and the humerus. Now, relating to the 3 apertures in the joint capsule, the synovial membrane forms a tubular sheath around the tendon of the bicep as it lies in the bicipital groove. The synovial membrane also facilitates the communication of the joint capsule with the subscapular as well as the infraspinatus bursae. The next ligament associated with the shoulder joint is the coracofemoral ligament, which extends from the root of the coracoid process to the anterior aspect of the great tubercle on humerus. The next ligament to be discussed is the transverse humeral ligament, which is a thick fibrous band extending between the greater and the lesser tubercle of the humerus. That is, it passes above the bicipital groove, converting the bicipital groove into a bicipital canal. And it is through this bicipital canal that the tendon of the long head of biceps passes, covered by a synovial sheath. Next up, we have the glenohumeral ligament. Anteriorly, the glenohumeral ligament has got 3 thickened bands called the superior, middle, and the inferior glenohumeral ligament bands, and they help to strengthen this ligament. A defect exists between the superior and the middle band, and this can lead to the anterior dislocation of the shoulder joint. Now coming to the accessory ligament of the shoulder joint, we have the coracoacromial ligament. The coracoacromial ligament extends from the coracoid process to the acromion process and protects the joint from superior aspect. The coracoacromial arch is formed by the coracoid process, the acromial process, and the coracoacromial ligament that passes in between them. It is the osteoligamentous structure that prevents the superior displacement of the shoulder joint, and the supraspinatus muscle passes under this arch. Now we shall discuss about the bursae associated with the shoulder joint. Bursae are fluid-filled membranous bag-like structures that allow free movement and reduces friction during joint movement. A large subacromial bursa lies between the coracoacromial arch and the tendon for the supraspinatus muscle. This facilitates the movement of the supraspinatus tendon. Sometimes the subacromial bursa continues downward beneath the deltoid muscle. Hence, it is sometimes called as subdeltoid bursa. It is the largest synovial bursa in the body and facilitates the movement of supraspinatus tendon beneath the coracoacromial arch. Next up, we have the subscapular bursa, which lies between the tendon of the subscapularis muscle and the neck of the scapula. The subscapular bursa protects the tendon of the subscapularis muscle from friction against the neck of the scapula. It communicates with the joint cavity in the anteroinferior aspect of the joint. We also have the infraspinatus bursa associated with the shoulder joint. The infraspinatus bursa lies in between the tendon of the infraspinatus muscle and the posterolateral aspect of the joint capsule. It communicates with the joint cavity. Now we shall discuss about the relations of the shoulder joint. The diagram shows the section of the shoulder joint as seen from the lateral side. We shall discuss about the relations in the superior, inferior, anterior, and the posterior aspect. Superiorly, we have the coracoacromial arch. Beneath the coracoacromial arch, we have the subacromial bursa, followed by the supraspinatus muscle and a part of the deltoid muscle. In the inferior aspect, the shoulder joint is related to the long head of triceps muscle, the axillary nerve, which usually gets damaged during the inferior dislocation of the joint, and also the posterior circumflex humeral vessel. In the anterior aspect, we see the subscapularis muscle and the subscapular bursa in the deepest level. Above that, we see the coracobrachialis muscle and short head of biceps and a part of the anterior fibers of deltoid muscle. The shoulder joint is posteriorly related to the infraspinatus muscle and the teres minor muscle and overlaid by the posterior fibers of deltoid muscle. Now we shall discuss about the vascular supply and the innervation of the shoulder joint. The arterial supply of the shoulder joint is by the anterior and the posterior circumflex femoral artery, by the suprascapular artery and the subscapular artery. The anterior and the posterior circumflex humeral arteries arises from the third part of the axillary artery. It forms an anastomosis around the surgical neck of the humerus and provides blood supply for the humeral head, the shoulder joint, and the associated muscles. The suprascapular artery arises from the thyrocervical trunk of the subclavian artery and supplies to the supraspinatus and the infraspinatus muscles and the other shoulder structures. The subscapular artery is the largest branch of the axillary artery from its third part, and it supplies blood to the scapula and the surrounding muscles and to the shoulder joint. It arises from the axillary artery and terminates by branching into thoracodorsal artery and the circumflex scapular artery. Now coming to the innervation of the shoulder joint, the primary nerves supplying the shoulder joint are the suprascapular nerve, the axillary nerve, along with the lateral pectoral and the subscapular nerves. All of them originate from the brachial plexus. They provide sensory innervation about the joint's position and motor signals to the associated muscles. The major function of joints is to bring about movement in the body. With respect to the shoulder joint, the major movements are flexion and extension, adduction and abduction, medial and the lateral rotation, and circumflexion. The clavicular head of the pectoralis major muscle and the anterior fibers of the deltoid muscle undergoes contraction to bring about the flexion movement of the shoulder joint. During the extension movement of the shoulder joint, the posterior fibers of the deltoid and the latissimus dorsi muscles undergo contraction. Adduction of the shoulder joint involves bringing the arms closer to the trunk. In order to bring the adduction of shoulder joint, the latissimus dorsi, the pectoralis major muscle, undergoes contraction. In abduction movement, the arms go away from the body. In order to bring about the abduction movement of the shoulder joint, the deltoid, the supraspinatus, the serratus anterior, and the trapezius muscles undergo contraction. The contraction of the subscapularis muscle, anterior part of the deltoid muscle, and teres major muscle is responsible for bringing medial rotation. The lateral rotation movement is brought about by the contraction of the posterior fibers of deltoid, the teres minor muscle, and the infraspinatus muscle. The total range of abduction of the shoulder joint is 180 degree. Out of this, the first 90 degree occurs at the glenohumeral joint. The 90 degree to the 120 degree abduction occurs because the humerus rotates laterally, and the 120 to 180 degree occurs because the scapula rotates forward on the chest wall. The supraspinatus muscle initiates the abduction, that is the 0 degree to the 15 degree abduction is caused by the supraspinatus muscle, while the majority of the abduction movement is caused by the deltoid muscle, that is from the 15 degree to the 90 degree abduction. The beyond 90 degree or the overhead abduction is caused by the trapezius and the serratus anterior muscles that causes the rotation of the scapula and allows for further elevation of the arm. Now we shall discuss about the clinical anatomy related to shoulder joint. The most common pathology related to the shoulder joint is the dislocation. It usually occurs when the arm is excessively extended and laterally rotated. Inferior dislocation is the most common type of dislocation because the capsular ligament is present all around the joint except inferiorly, so the joint is least supported inferiorly. Axillary nerve injury can occur as a complication of inferior dislocation of the shoulder joint due to its close proximity to the joint in that region. Yet another pathology associated with the shoulder joint are the rotator cuff disorders. The most common rotator cuff disorders are the calcific supraspinatus tendinitis and the subacromial bursitis. Rotator cuff disorders occur mostly in males above 50 years of age, and they are caused because of repetitive use of upper limb above the horizontal level, as in swimming, weightlifting, etc. We shall discuss first about the calcific supraspinatus tendinitis. It is caused because of the deposition of calcium in the supraspinatus tendon. The deposited calcium irritates the overlying subacromial bursa and causes subacromial bursitis. Consequently, when the arm is abducted, the inflamed bursa is caught between the tendon and the acromion process and causes severe pain. In most people, the pain occurs during the 60 degree to 120 degree of abduction. So it is also known as the painful arm syndrome. Subacromial bursitis is a condition where the subacromial bursa is inflamed. The Doban's sign is used to elicit subacromial bursitis. To conduct the Doban's sign, the patient is asked to adduct the arm, that is to keep the arm close to the body. Now in the adducted position, pressure is applied over the subacromial space just below the deltoid. In case of a positive Doban's test, pain is elicited when pressure is applied in this position on the adducted arm, but pain would disappear when the pressure is applied on abducted arm. This is because in an abducted arm, the bursa would disappear below the acromion process. Adhesive capsulitis or frozen shoulder is a common shoulder pathology occurring in the 40 to 60-year age group. It occurs due to a shrinkage of the joint capsule, and the patient clinically complains of progressively increasing pain in the shoulder, stiffness of the shoulder joint, and restriction of all movements. Septic arthritis of the shoulder joint is a serious and rare infection that causes significant damage to the joint if not treated properly. Septic arthritis is characterized by severe pain, reduced range of motion, and symptoms like fever. Early diagnosis and treatments, including antibiotic usage, joint drainage, etc., are crucial to prevent long-term complication. Thus, we have covered the major anatomical points regarding the shoulder joint. Hope it was helpful.